6 o'clock, we can start.
A very good evening to everyone. I welcome you all to the Saarc Association of Anesthesiologists Continuous Professional Development Program. We gather here every month to enrich ourselves on very important topics of anesthesia and pain management. Without wasting much time, I would like to introduce Professor Anjali Bhure ma'am uh, to introduce the webinar. Professor Anjali Bhure is the professor and head of Medical Sciences, and she has many publications to her credit. She is a vice president ISA National and GC member ISA National from 2016 to 2019. She was also the honorary secretary West Zone of ISA from 2009 to 2015, and she's got various awards to her credit. Professor Anjali Bhure.
Dr. Anjali, please unmute yourself.
You're muted, ma'am.
So sorry. A warm welcome to all the attendees in this continuous professional development program. Education is the foundation upon which we build our future. Honorable President Dr. Venkat Giri Sir, Saarc AA, Professor Naveen Malhotra Secretary, Dr. Virender Sharma Treasurer, all the honorable presidents, secretaries, treasurers, office bearers at national level of societies of anesthesiologists of Saarc AA countries, esteemed speakers, chairpersons, and my dear friends. In today's program, we are traversing a journey from pediatrics to geriatric population. Perioperative fluid, electrolyte, and blood transfusion therapies for infant and children can be very confusing due to the numerous opinions, formulas, and clinical application which can result in a picture which is often misleading. Perioperatively, crystalloid, colloids, and blood components are required to meet the ongoing losses and for maintaining cardiovascular stability for adequate tissue perfusion. A meticulous fluid and blood transfusion management is required in pediatric patients because of an extremely limited margins for error. Hence, it becomes mandatory for an anesthesiologist to learn the intricacies of fluid and blood transfusion therapy in this pediatric population. Dr. Anida Malde is a known name in the field of pediatric anesthesia in India. The second deliberation is impact of frailty on surgical outcomes. Frailty is a condition which is characterized by loss of biological reserve and is a condition where there is failure of physiological mechanism and being to a range of adverse outcomes, including increased risk of morbidity, mortality, and of course, most importantly, loss of independence in the perioperative period. With increased recognition of the prevalence of frailty in surgical population and the impact on postoperative outcomes, today's faculty, Dr. Vishakha Karnar, is here to guide us on how to take perioperative care for people living with frailty who are undergoing elective as well as emergency surgery. Thank you very much. Over to Jyotsna and Neha for further proceedings.
We would now like to invite Professor Naveen Malhotra sir to give the welcome address. Professor Naveen Malhotra sir is the director of AS Pain Management Center, Rohtak, Haryana, and he is a very renowned figure. And he was the former senior professor and head at Pain Management Center, PJMS Rohtak. Sir has got many awards to his credit. He is the president RSCAP. He is the chief advisor for 70th ISACON 2023, which was held in Gurgaon, Haryana. He was the honorary secretary of ISA National and is the honorary secretary of Saarc Association of Anesthesiologists. He is the deputy chair of Asian Australasian Regional Section of WFSA and member Intensive and Critical Care Medicine Committee of WFSA. Welcome, sir.
Thank you, Dr. Josna and Dr. Neha Sinha, the coordinators of Saarc AA CPDP program today. Uh, Dear Dr. Venkatgiri, President ISA National, Saarc AA, and past President of ISA National, other dignitaries from all the countries, very respected speakers. It's a privilege that we are now uh, continuing with the Saarc AA CPDP program, which is going into its second cycle now. We completed last month the full one cycle, and participation from all countries, from Afghanistan, from Malaysia, from Maldives, from Bhutan, and also from Bangladesh, Nepal, Pakistan, Sri Lanka, and India. This will continue next month also, and soon we will be having after that Saarc YuvaCon, which will be curtain raiser for Saarc AA Con 2024, which is going to be held in the month of December at Dhaka, Bangladesh. And we all have received warm invitation from Dr. Banik and Dr. Kavasar for their Golden Jubilee celebrations, which are clubbed with the Saarc AA Con 2024 at Bangladesh, Dhaka. Saarc AA has been more active than ever, and we have utilized the virtual platform to bridge the gaps, to bring closer all the members, associations, and the member association office bearers and the members, so that they can interact both clinically and academically. I'm very sure soon we will be able to start the student exchange program and the fellowships under the banner of Saarc AA CPDP. I personally thank both the speakers, respected Dr. Anila Malde Madam and Dr. Vishaka from Sri Lanka, for accepting our invitation to be the speakers today. Speakers of the scientific program are the backbone, so I won't stand between their knowledge and wisdom and which they will share with the delegates. So welcome all to this Saarc AA CPDP program of July 2024. Thank you very much.
Thank you, sir. Now I would like to welcome Dr. Venkatgiri KM, President Saarc Association of Anesthesiologists, to address. Dr. Venkatgiri is a senior consultant, United Medical Center and Carewell Hospital, Kasaragod, Kerala. He has held various senior positions, like he was a past secretary and GC member ISA National, past secretary and secretary ISA Kerala, past president and secretary ISA Kasaragod. He is the Professional Wellbeing Committee member of WFSA from 2016 to 2024. He was the past Joint Secretary and Vice President IMA Kerala, past President and Secretary IMA Kasaragod, and he has attended more than 100 state, zonal, national, international conferences. He is also the co-author for ISA calls guidelines. Welcome, sir.
Thank you. Good evening, everybody. As we have decided earlier, we are going ahead with this Saarc CPDP every month, last Friday, 6 o'clock, and we have finished one round, and now we are in the second round of this Saarc Continuous Professional Development Program. I hope you all enjoy, and people from all the Saarc countries come attend this program and know what is happening in other countries and develop in other countries. And wish that you will all enjoy. I thank the faculty, chairpersons who have prepared for this talk and enlightening the people of Saarc countries and others too. Simultaneously, I just want to remind you that December 2nd week, we have Saarc Congress at Bangladesh, and try to attend in large numbers and enjoy that Saarc conference at Dhaka, Bangla. Thank you.
Thank you, sir. Now I would like to invite our speaker, Professor Anjali D. Malde. Professor Anjali is Professor and Head of Department of Anesthesia at the Lokmanya Tilak Municipal.
I correct you, Dr. Josna, Dr. Professor Anila D. Malde.
Professor Anila D. Malde, sorry. And she is Professor and Head at the Department of Anesthesia at Lokmanya Tilak Municipal Medical College and General Hospital, Sion, Mumbai. She is the MD and DA guide for Maharashtra University of Health Sciences, faculty professor for postdoctoral fellowship course in pediatric anesthesiology at LTMMC and LTMGH since 2012. She is the associate editor for pediatric anesthesia IJA, past president Maharashtra State Chapter IAPA, and created a state-of-art museum at LTMMC. She has got various awards as best worker, as the first prize for best paper and co-authors for best paper. And she is the abstract coordinator for Asian Society of Pediatric Anesthesiology Conference 2017 and ISACON 2011. She is the editor of the book A Practical Approach to Anesthesia for Emergency Surgery and editor for Pediatric Anesthesia and Comprehensive Clinical Anesthesia. She has got numerous publications, 40 publications in journals, 21 textbook chapters, and 45 CME book chapters, and attended various conferences. Welcome, ma'am. It is our privilege to hear from you.
Thank you, everyone. I think you can play the lecture.
So, yeah, madam has a backup sent us a lecture recording. It's an honor for us to play that. So, while in the meantime, I'll request everybody to please unmute to mute themselves. Please share me. No. Download.
Hello, friends. I'm going to give some practical tips.
Share with sound आएगा ना? Share sound.
For fluid and blood transfusion in pediatric patient. We give fluids to maintain normal volemia, normal tissue perfusion, metabolic function, electrolyte, and acid-base status. Distribution of body water is different in different age groups. 80% of the newborn body weight is water. Now, if you see over here, the intracellular fluid compartment is constant. So what is changing over here is the extracellular fluid compartment. Now, in ECF also, the plasma is constant across the age group. What is changing is the interstitial fluid. As you can see over here, in the preterm babies, the total body water, extracellular water, the sodium and chloride, all are higher. The insensible water loss occurs through the skin and the respiratory tract. The preterm, the baby, small for a gestational age baby, there's increase in the total body water and extracellular water. With the prematurity, again, because of multiple reasons like increase in the ratio of the surface area to respiratory tract, thin skin, increased skin blood flow, increased skin permeability, increased total body water, and increased respiratory rate, the insensible water loss is quite high. If there's increase in the body temperature, ambient temperature, etc., then it will increase. But if you keep them in an incubator, increase ambient humidity, cover them, then it will decrease. The smaller the weight, more is the insensible water loss. The kidney function, that is renal blood flow, GFR, and maximum concentrating ability is low in the neonates. The fractional excretion of sodium is high in a premature baby. Cardiac output, which is dependent on heart rate and myocardial contractility, both are near maximum at baseline and cannot increase further with the volume overload. There's a narrower range of the cerebral blood flow autoregulation. So with hypoxia, acidosis, seizures, or decrease in the diastolic blood pressure, there's disruption. So excessive fluid can cause increase in the BP and rupture of fragile vessels, and hypovolemia can cause cerebral ischemia. The daily fluid requirement is as per the weight of the baby, more than or equal to 2.5 kg baby requires 60 ml per kg per day. But as the weight reduces by 500 grams, then the baby will further require more by 10 ml per kg per day. And per day, there is further increase in the requirement by 10 ml per kg per day to a maximum of 150 ml per kg per day. Aminoven can be given as 1 gram per kg per day and can be started on a day of life 1. The sodium, the first 12 hours is not needed, whereas after 12 to 24 hours, the sodium is needed in extremely low birth weight babies and in all by day 2. The potassium in the cord blood is high, and over 48 to 72 hours, it will settle down. So potassium is not given in the first 48 hours, and day 3-4 onwards, the potassium is added. Bicarbonate, again, it is low in a preterm baby because they have a limited tubular excretion of weak organic acids and incomplete tubular reabsorption of bicarbonate. So in a very small premature, you need to give soda bicarbonate 1 to 2 millimoles per kg per day. IV 40 milligram per kg per day elemental calcium, that comes to 4 ml per kg per day of 10% calcium gluconate, especially is required in a preterm babies. Glycogen storage and glycogenolysis are developed in the last trimester of pregnancy. So preterm newborns develop hypoglycemia in the first 24 to 48 hours of the life. So term neonates require 3 to 5 and preterm neonates 5 to 6 milligram per kg per minute. We have availability of concentrated RL ampule, and when you add 1 ampule of concentrated RL to 500 ml of water, ultimate electrolyte concentration is like a RL pint. So that means 1 ml of concentrated RL gives sodium of 3.275 millimoles. Now let's learn with example. In a 2 kg baby, day of life 1, the water requirement is 70 ml per kg per day. That means 140 ml in this baby. Aminoven 2 gram per kg per day. So that comes to 4 grams, and that is there in the 40 ml. So final composition we can give is 100 ml D10% plus 40 ml aminoven. Now this will contain glucose of 3.47 mg per kg per minute. Now if the same baby goes to day 3 life, then 90 ml per kg per day. So 180 ml per day will be required. Aminoven will give 40 ml. Sodium requirement is 3 millimoles per kg per day, and a concentrated RL gives 3 millimoles per ml. So we need to give 6 ml millimoles per day. So final composition we can do is 136 ml D10% plus 40 ml aminoven plus 2 ml concentrated RL plus 2 ml KCl. Now what about intraoperative management? In a short surgery with mild tissue trauma, we can give lactating plus 5% dextrose at maintenance rate. But if it's a major surgery or a moderate to severe tumor trauma is there, then in addition to this, you require replacement of glucose-free isotonic solution. Now coming to infants and children, there are 3 components of IV fluid therapy. One is maintenance of water and electrolytes to cover insensible urinary losses. Second is replacement of pre-existing deficits like NP or excessive losses. And third is a replacement of ongoing losses because of exposure, blood loss, and third space loss. Now, how was Holiday-Sicker formula derived? Metabolism produces heat, which has to be dissipated by insensible water loss and solute by urine. And normally, these losses are there. So 100 ml of water is required for each 100 calories of expended energy. Smaller the child, more is the metabolic demand and increased body surface area to weight ratio. So there is increased water need. And that has given rise to this daily and hourly 4-to-1 formula. So the 3 to 10 kg, 100 ml per kg per day, that comes to 4 ml per kg per hour. In a 10 to 20 kg, 1000 ml plus 50 ml per kg for each kg from 11 to 20 kg. And for more than 20 kg, 1500 ml plus 20 ml per kg for each kg more than 20 kg. So this gives rise to our commonly known as a 4 ml per kg per hour. In a 10 to 20 kg, 40 ml plus per hour plus 2 ml per kg per hour for each kg from 11 to 20 kg. And here for more than 20 kg, it is 60 ml per hour plus 1 ml per kg per hour for each kg more than 20 kg. So this famous 4-to-1 formula has come. Now considering electrolyte of human and cow's milk, 2 of potassium and chloride and 3 ml equivalent per 100 calorie per day of sodium is needed to be given. And this is met by 5% dextrose plus 0.2% saline or isolate P. But this does not include fluid deficit, third space losses, modification because of hyper or hypothermia, or requirement by unusual metabolic demands, we need to avoid hypotonic fluid for replacement of third space losses and other deficits. Now we follow the ASA fasting guidelines, and that allows clear liquids up to 2 hours before anesthesia. So if the child is fasting for 4 to 6 hours and child is old enough without significant pre-existing disease, then there is usually no evidence of intravascular compromise. So if ASA fasting guidelines are followed, on or absence of evidence of intravascular fluid deficit or hypotension in response to induction of GA is there, then there is no need to replace fasting deficit. So assessment of the current status is more important than simple calculations. Now, what is the role of preoperative fasting times? Perioperative fasting times for children should be as short as possible to prevent discomfort, dehydration, and ketoacidosis. If pre-op and post-op fasting times are short, perioperative intravenous fluid therapies should not necessarily be performed in children beyond the neonatal age who drink sufficient volumes and undergo short procedures less than 1 hour with a venous access in place. Replacement of pre-existing deficit will be required if there's something like vomiting, diarrhea, fever, or intestinal obstruction, very common in emergency surgeries. Now, rate and volume will depend on the type and indication of surgery, hemodynamic status, and coexisting problems. And most of the time, LR 10 to 20 ml per kg will suffice. If there's ongoing loss like traumatic hemorrhage, then fluid resuscitation is initiated before surgery and it is further continued intraoperatively. If surgery is not urgent, like for example in CHPFs, where you have a hyponatremic, hypochloremic, hypokalemic, metabolic alkalosis with a variable degree of dehydration, then you need to correct it. So you are going to give 20 ml per kg bolus of isotonic saline, 2 boluses if the chloride is less than 97, and 3 boluses if chloride is less than equal to 85. And a further resuscitation can be with the 5% dextrose in 0.45% saline at 1.5 times the maintenance rate, that is 6 ml per kg per hour. And unless there's a renal insufficiency, 2 to 4 milliequivalent potassium can be added per 100 ml. And we need to monitor electrolytes. Now, again, let's learn with the example. So a diagnosed case of pyloric stenosis, neonate of 3 kg with serum sodium of 125, potassium of 2.5, chloride of 86, pH of 7.5, and mild dehydration. So that means the fluid deficit is 50 ml per kg. Okay, so including maintenance, you need to give 450 ml. The sodium deficit, including maintenance, 36 milliequivalent, potassium deficit plus maintenance, 7.8, and glucose, we need to give 21.60 gram. So if this can be given with 450 ml, 5% dextrose with 0.45% saline plus 4 ml of KCl over 24 hours, that will suffice. Now, third type of loss is ongoing losses and third spacing. So either it could be in the form of whole blood loss, direct evaporation in very small infants, or surgical trauma to cell membrane causes hypoxic injury, creating a capillary leak, resulting in extravasation of isotonic protein containing fluid into interstitial compartment, and thus is called as a commonly third space loss. Or it could be anesthetic induced vasodilatation, increased capacitance, and relative hypovolemia, which is called as a virtual loss. Now, these are difficult to quantify. Estimates are usually quite rough. So one has to be vigilant and prompt in action, because the smaller the child, lesser is the circulating volume and safety margin is very low. A small loss for an adult becomes very significant for a tiny infant. Now, isotonic crystalloids are used to replace third space losses. And depending on the tissue trauma, we can give 3 to 4, 5 to 7, or more than equal to 10 for mild, moderate, and severe in form of ml per kg per hour. If we give too much, then it will cause hemodilution, increased capillary pressure, whole body salt and water overload. Now, if a relatively healthy child is there, most excess will be excreted over next post-op 2 days. But if the child is impaired with the pulmonary, cardiac, or renal function, then there could be pulmonary edema, bowel swelling, laryngotracheal edema. Now, which fluid will be given? Isotonic fluid in all these children. For example, isotonic fluid, you can give sodium chloride, but it has a high chloride, so it will cause hypochloremic acidosis. So it is better to give balanced salt solution, which can be either containing lactate, like lactated ringers, or acetated ringers, or plasma light, which contains gluconate and acetate, and stirofundin, which again causes gives acetate. Now, acetate has some advantage. Bicarbonate production will be faster, oxygen consumption and respiratory quotient will be less. It can be metabolized by all tissues. It can be metabolized even in shock. It doesn't affect this thing. It doesn't cause gluconeogenesis, so there is no hyperglycemia, and binding to calcium doesn't occur, so you can give it the blood products also, and lactate can be used as a hypoxia marker. Now, which type of fluid is not to be given? Whenever the sodium is low, hypotonic fluid is not to be given. Now, what about glucose? In neonates, severe hypoglycemia can cause permanent neurodevelopmental impairment. And even if mild hypoglycemia is there, when it is combined with the mild hypoxia or ischemia, it can cause cerebral injury in immature neonates. So neonates need glucose in the maintenance fluid. But if it's a bigger infants and children, incidence of preoperative hypoglycemia is very low and should not occur if you are following the AC fasting guideline. In fact, the stress-induced hyperglycemia plus dextrose can cause osmotic diuresis, which can lead to dehydration and electrolyte abnormalities. And in case of ischemia or hypoxia, there'll be impairment of metabolism of excess glucose. So there'll be accumulation of lactate, which will cause intracellular acidosis, cellular death, and neurological impairment. So we have to avoid hyperglycemia in neurosurgery. Glucose-containing solution should not be used to replace intraoperative fluid losses. In a child of 6 months to 5-year-old, we can give 0.9 to 1% dextrose. In the UK, they have started making the ready-made solution. In India, it is yet not available. And after the age of 5 years, glucose-free isotonic solutions can be given. We have to be careful if the child is less than 6 months, debilitated, malnourished, or undergoing cardiac surgery, or is having endocrinopathies, or on beta blockers, or receiving hyperalimentation, or undergoing prolonged surgical procedures, or has been given a lot of regional anesthesia, which is reducing stress. In these cases, vigilant glucose monitoring is required and higher glucose concentration may be needed. Now, European consensus statement came out in the Berlin in September 2010, which says that the solution should have a physiological osmolarity to avoid hyponatremia. It should have 1 to 2.5% instead of 5% glucose to avoid hypoglycemia, lipolysis, and hyperglycemia, and should have metabolic anions like acetate, lactate, or malate as a bicarbonate precursor to prevent hyperchloremic acidosis. Now, what about colloids? Surgery in aseptic neonates present conditions that may compromise normal endothelial glycocalyx integrity and so enhance extravasation of albumin and other colloids into interstitial space. And this will compromise lung function and wound healing. So colloids like albumin, gelatin, hydroxyethyl starch are associated with more adverse drug reactions than balanced electrolyte solution. So only thing is, in children with hypovolemia, if crystalloids are not sufficient to maintain hemodynamic stability and the blood products are either not to be given or not available, then one can use colloid intraoperatively in a restrictive approach. You can give any one of this like albumin gel or HES 130 as a 5 to 10 ml per kg, and maximum dose of 30 ml per kg of HES can be given. We need to monitor the hydration status clinically by capillary refill time, skin turgor, fontanelle, or fluid responsive like by autotransfusion maneuver like pressure on the liver. In a major surgery, one can do arterial and CVP catheterization and regular ABGs. And in case of negative trends like decreases CVO2 or decreased basic cells or lactate increase, countermeasures should be taken early. Now, to simplify, this article came out which says that perioperative fluid of management in children rule of 10 means background infusion of balanced isotonic electrolyte solution with 1 to 2% glucose can be given as 10 ml per kg per hour. In most of the ambulatory surgeries, this will suffice. Now, if it's a major surgery, then fluid therapy may be needed for the exposure losses, and that should be in the form of balanced salt solution 10 to 20 ml per kg. In addition, if needed, hemodynamic instability is there, volume therapy in the form of albumin, gelatin, or HES, 5 to 10 ml per kg can be given. And if there's a major blood loss, then blood and blood components, RBC, FFP, and platelets, 10 ml per kg can be given. Now, all the studies with the large sample size have shown that in children, the risk of aspiration is quite low. It's only 0.007% to 0.1%. And that too, the incidence of postoperative ventilation among those children who aspirated is further low. So what is suggested is preoperatively keep the fasting time short, clear fluids up to 1 hour pre-op. Postoperatively allow the children to eat and drink soon after the procedure. And if it's a minor procedure, you just need a background infusion of 10 ml per kg per hour of balanced salt with 1% dextrose. If it's an intermediate procedure, then in addition to this, you will need some balanced salt solution as additional fluid requirement. Plus, to maintain hemodynamic stability, you may need colloids. And if it's a supramajor procedure, then you may need the blood products if there's a critical hemodilution. Now, whenever we are giving fluids, we have to remember that there should not be any postoperative hyponatremia, because there's a large amount of arginine vasopressin secretion, either because of pre-existing condition or because of neuroendocrine activation by stress. And further, if we don't monitor and if there is delay in recognition, and majority of the time because the ongoing losses are replaced with hypotonic instead of isotonic fluid, the person develops hyponatremia. And in the child, because they have a relatively large brain to intracranial volume ratio, relatively small CSF volume and hence buffer capacity, immaturity of sodium potassium ATPase pump, high amount of brain intracellular sodium concentration, and plus the child will not develop the headache, nausea, etc. And so it will not get recognized, and it will get recognized directly as a respiratory arrest. The hyponatremia is very common. And all of us must remember there's something difference between osmolarity and tonicity. Now, osmolarity, even a 5% dextrose is almost isoosmolar. In vitro osmolarity is 286 milliosmol per liter. But tonicity is a total concentration of solutes that exert osmotic forces across a membrane in vivo. So 5% dextrose, when you give, the dextrose will get rapidly metabolized. So what will be remaining is a water, and in vivo tonicity of this is 0. So we need to remember, we cannot give hyponatremic solutions. We have to give isotonic fluids. Now, can we give 0.9% saline? It will cause hyponatremia, edema, hypertension, chloride-induced acute kidney injury. So we need to give LR. But LR is not containing any glucose. So in the post-operative period, we may need to add dextrose 5 to 10%. Now, at what rate it has to be given? It is given at a half rate as a maintenance compared to what we were giving intraoperatively. So instead of 4 to 1, this will become 1.5. Now, if the child does not or cannot tolerate orals after 6 to 12 hours, then we need to give 5% dextrose with half strength saline at a rate of holy disregard, that is 4 to 1 formula. We need to have a serial monitoring of serum electrolytes once daily. Now, if at all hyponatremia occurs, then we need to give treatment with bolus injection of 2 ml per kg of 3% NaCl slowly. The bolus can be repeated once or twice. The purpose is to eliminate the symptoms or raise the concentration of serum sodium by 5 to 6 milliequivalent per liter in 1 or 2 hours. Check the plasma. Stop 3% NaCl therapy. Once the child is free of symptoms, awake, alert, response to commands, and there is a resolution of headache or nausea. And the serum sodium, there's a sharp rise, 10 milliequivalent per liter in first 5 hours. After hyponatremia symptoms have resolved, ensure that the plasma sodium does not increase by more than 12 millimoles per liter, because otherwise it will cause pontine myelinolysis. Now, what are the indications of red blood cells? Mainly to increase oxygen carrying capacity or to dilute concentration of abnormal hemoglobin moieties in patients with sickle cell disease or thalassemia. And a transfusion trigger for patients less than 4 months old are more liberal, because these children have a limited ability to produce erythropoietin or increase cardiac output or release oxygen to the tissues. So if you see the neonates, again, the transfusion trigger will vary depending on whether the baby is off oxygen or on oxygen CPAP or baby is on a mechanical ventilation. So it can range anyway, and depending on the age, number of hours of life. So depending on that, it can vary from 7.5 to 8.5 in a baby who's off oxygen in a day 8 to 14, compared to a ventilated baby in the first 24 hours, that will be 12 gram%. Okay. Now coming to children less than 4 months of age. Whenever there is a hemoglobin less than 7 gram% with low retic count and signs of anemia, or if there's acute blood loss of more than 15 to 20% total body volume, or intraoperative blood loss of more than 15%, then we need to replace with the blood. If hemoglobin is less than 10 gram% and the child is on a CPAP or mechanical ventilation with airway pressure less than 6 or FiO2 less than 35, then you need to give. If the child is requiring higher CPAP pressures or higher FiO2, then we have to start transfusion even at hemoglobin of 12. And if the child is having a congenital cyanotic heart disease, CCF or ECMO, then even at 15, we need to start giving RBCs. Children with more than or equal to 4 months of age, it will be slightly varying. Here, again, the 7 gram is the target, or 15% of total body volume loss is a target. But instead of less than 4 months, when we are giving a 10 gram percent, here we can wait up to 8 gram percent. Or children with the severe cardiopulmonary disease or on ECMO, there we were giving at 15 gram percent, here we have to give at a 13 gram percent. And plus the children like beta thalassemia, red cell aplasia, they will require the transfusion. Circulating blood volume will differ. In a child, it will be 70, whereas in a preterm baby, it will be 90 to 100 ml per kg. All of us know how to calculate the maximum allowable blood loss, that is EBV into hematocrit initial minus hematocrit target divided by hematocrit initial. And how much Paxil you will give, that will be desired hematocrit minus observed hematocrit divided by the Paxil hematocrit multiplied by the estimated blood volume. Okay, pre-transfusion test in a neonates, it is very important to test the mother sample as well as the neonatal sample. Now, when we need to give fresh frozen plasma as a replacement of the coagulation factors in a bleeding patient or one who's about to undergo invasive procedure and is having a coagulopathy, or whenever specific factor concentrates are not available, or PT-INR is more than 1.5, PTT more than 1.5 in a bleeding patient or one who's undergoing invasive procedure, or during therapeutic plasma exchange or as a reversal of warfarin. But please do not give FFP as a routine prophylaxis against peri or intraventricular hemorrhage in preterm neonate, or as a volume replacement solution, or just to correct abnormalities of the clotting screen. Then what about platelets? Platelets less than 30,000, consider transfusion. Platelets between 30 to 49,000 if the baby is in the first week of life or less than 1 kg weight, or prior grade 3 intraventricular hemorrhage is there in the last 48 to 72 hours, or there is concomitant coagulopathy, or it's a critically ill or septic, or during invasive procedures. Platelet count with 50 to 90,000 if the baby is having a bleeding, and platelet of 1 lakh per cubic millimeter if the baby is undergoing neurosurgery. What about cryoprecipitate? It contains factor 8, von Willebrand factor, factor 13, and fibrinogen. Dose is 1 unit per 5 to 10 kg baby weight, and it is indicated whenever fibrinogen is less than 150 milligram percent with microvascular bleeding, or massive transfusion with fibrinogen concentration less than 150 milligram percent in active bleeding, and deficiency of fibrinogen, dysfibrinogenemia, or fibrinogenemia, etc. Now, when we call it as a massive blood loss more than 1 EBV in 24 hours, or blood loss of 50% EBV within 3 hours, or transfusion at a rate of 10% of total blood volume every 10 minutes. Now, these are likely during trauma, liver transplant, cardiac surgery, major spinal surgery, cranial vault surgery, neurosurgical procedures like arteriovenous malformation, vein of Galen. Now, we have to remember that we have to early recognize, educate whole team, do active resuscitation and control bleeding, seek specialist assistance, give O negative blood group till the specific red cells are available, and it should be ml per kg body weight calculation. Anticipate and treat coagulopathy and thrombocytopenia, give tranexamic acid, avoid hypothermia, hypocalcemia, acidosis, and hyperkalemia. A ratio of at least 1 FFP per 2 RBCs initially, and if required, 1 FFP, 1 RBC, 1 platelet, 1 cryoprecipitate can be given. Platelet and cryoprecipitate must be considered if active bleeding persists after initial resuscitation. So appropriate allocates, for example, RBC 20 ml per kg, FFP 20 ml per kg, platelets 15 to 20 ml per kg, cryoprecipitate 10 ml per kg can be given. And our aim should be to maintain hemoglobin of 8, fibrinogen more than 150 milligram percent, PT ratio less than 1.5, and platelet count more than 75,000. Calcium may be needed to be given. Calcium gluconate can be given 15 to 30 milligram per kg whenever the rapid transfusion of FFP or whole blood is there at a rate more than 1 ml per kg per minute. Acidosis can be improved with soda bicarb. Hyperkalemia needs to be treated. So in conclusions, neonates have a high insensible losses. So reduce insensible water loss rather than giving more fluids. 0.9 to 1% dextrose is sufficient in majority except neonates. The replacement of ongoing losses should be with the isotonic fluid. Be vigilant to detect post-op hyponatremia. Avoid coagulopathy, acidosis, and hypothermia in massive blood loss. Thank you.
Dr. Anila, ma'am, you explained this very intricate topic in an extremely comprehensive and yet simplified manner. There are few questions in the chat box.
Yeah. Let me see the
I asked.
in the chat box.
Ma'am, ma'am, the first question is, what is the concentration of albumin and what is it if it's recommended?
5% albumin. 5% albumin.
Okay, ma'am.
Depending on the volume status, you can give 5 to 10 ml per kg. More so, it is recommended in neonates, not in the larger children. Did you hear me?
Yes, ma'am.
Hello?
Yes, ma'am.
Yeah.
Hello,
So
yes, ma'am, we can hear, ma'am. Very
5
can
to
hear
10 ml per kg, depending on the volume status, more so in the neonates.
Okay. And there's one more question. Any fluid recommendations for neonates or young infants on inotropes for GI surgery?
Better to give acetate containing fluid, balanced salt solution, acetate containing fluid, because if the patient is in low volume status, or tissue perfusion is less and patient is developing lactic acidosis, if you are giving a lactate containing fluid, it may interfere in the readings of lactate levels. So if available, you can give acetate containing fluids. If not available, one can give lactated ringer.
Okay.
Ma'am, what is the latest status of Isolite P and balanced salt solutions in the neonates? We have been listening about Isolite P for a very long time.
Yeah, so in the neonates, intraoperatively, and at least first 12 hours post surgery, it should be balanced salt solution, because whatever is getting lost by evaporation, it is like a extracellular fluid. So you need to give something which is having a concentration similar to the extracellular fluid. But later on, say after 12 hours surgery, 12 to 14 or 24 hours after surgery, then one need to give the calculated. And that is why I gave the example, how do we calculate? The concentrated ringer ampules are available. So our neonatologists as well as pediatric surgeons and we people, when we are managing the cases, we calculate and give exactly. But the smaller places where the calculated things are not available, give the isolite P, because isolite P has a sodium concentration of 23 milliequivalent per liter. So neonate weighing a 3 kg would require about 9 milliequivalent of sodium per day. And the fluid of, say, about if the baby is getting 100 ml per kg, baby is receiving 300 ml of fluid. So that means the baby will get appropriate amount of sodium. So isolite P as such is not indicated in the perioperative period. It is for the maintenance fluid more on the medical side in the neonates. But when the baby is coming with the acute
Regarding
emergency, for example, an infant is coming with the, say, excessive vomiting, diarrhea, etc., then again it is better to give supplementary ringer lactate. Now, of course, in those cases, twice in a day, a daily electrolyte needs to be done, and the fluid has to be adjusted as per the electrolyte levels and clinical status of hydration.
Yes,
ma'am, any particular case or situation where isolite P is to be avoided?
See, now, immediate post surgery and during surgery, isolite P definitely needs to be avoided, because this patient produces a lot of arginine vasopressin during surgery. And so there is a fluid retention and they develop hyponatremia. And because isolite P is having very low sodium content, these babies will develop the hyponatremia further and they can develop the seizures. So it has to be avoided in those.
Right, ma'am. Ma'am, another question regarding cardiac neonates with cardiac dysfunctions. Any fluid of choice in neonates who are undergoing cardiac surgery?
See, neonates undergoing cardiac surgery, obviously they will, if they are undergoing in the CP bypass, they will receive the blood prime, they will receive albumin in the prime solution. And otherwise, the fluid of choice would be again balanced salt solution, that would be acetate containing fluid.
Okay, ma'am. And ma'am, any in patients with VSD, any formula or any way to calculate the fluid, or is it the regular one?
Pardon? Can you
Ma'am,
repeat the question?
yes, ma'am. Ma'am, in pediatric patients with VSD, how to calculate fluid? This is a question that is up in the chat box.
Yeah. So, any patient who's developing congestive cardiac failure, so if any signs of congestive cardiac failure are there, then we need to restrict the fluid by 1/3 amount. That means 2/3 of the fluid we can give. So, suppose in a say a baby neonate who's 2.5 kg and who's coming at a 6th day of life for surgery. Now, such a 6th day of life, the baby's normal requirement would have been about 100 ml per kg or 110 ml per kg. So here you restrict it to 2/3 amount. So you'll give about 65 ml per kg per day. Now these are guidelines, but depending on the clinical signs and depending on the daily intake output status, depending on the daily electrolyte and hydration status, you need to adjust.
Right, ma'am. Ma'am, a fluid of choice in babies with renal insufficiency. Dr. Raghunandan has asked this question, ma'am.
Yeah, see, the babies, unless they are having a hyperkalemia, they still need to be given in a perioperative period lactated ringer solution. So if the baby is having a very high potassium initially because of the severe renal failure, you need to do preoperatively potassium levels. And you see, usually if it is a more than 5 milliequivalent per liter, then intraoperatively I will avoid ringer lactate and I will give dextrose with half strength saline if depending on the age. If a bigger child is there, dextrose with saline, otherwise dextrose with half strength saline I will give. But otherwise, most of the children, they tolerate quite well ringer lactate. Now, there are occasions like, when say bilateral ureteric reimplantation is going on and the creatinine in a 4-year-old child is already 5 milligram percent. Now, such a kind of patient can develop following blood transfusion severe hyperkalemia. So you have to be careful. So in those cases, the preventive steps have to be taken. And right from the beginning, you don't give, ringer lactate containing fluid. I mean, you can give the fluid without potassium. So dextrose with half strength saline can be given in those cases. And obviously,
Right.
you need to monitor the venous blood gases and the electrolytes intraoperatively also. So we have to be extremely careful with the blood transfusion in these cases. Normally, as such, without blood transfusion, they don't develop severe hyperkalemia. But I have seen the patients with the blood transfusion, the smaller the child, they can develop hyperkalemia.
Thank you, ma'am. And ma'am, one last question from Dr. Rajni Sundar. What is the role of plasmolite?
Plasmolite is an acetate containing fluid. It is more or less similar to the ringer lactate, but additional advantage would be that oxygen consumption while conversion of acetate to bicarbonate is much lower. And secondly, patients with the liver failure and all, or patients undergoing liver transplantation, it is better to give the acetate containing fluid plasma light rather than the ringer lactate. Or whenever shock status is there and the liver perfusion is getting affected, in those cases also, when you use ringer lactate, you won't be able to use the lactate as a biomarker. So in those cases, acetate containing fluid would be preferred. But otherwise, if you have in a large scale economic considerations, lactated ringer will suffice in most of the cases. So cases with the liver failure, severe shock on the ionotropes, or liver transplant, those cases plasma light would be definitely preferred. And if available freely in your institute, you can afford it, then yes, definitely you'll use plasma light compared to the ring electric.
Thank you so much, ma'am.
Thank you, ma'am.
Extremely enriching session on blood
Thank you,
transfusion.
Dr. Anila Malde madam, for that excellent talk and super excellent discussions. It was pleasure to have you with us, sharing your pulse of knowledge and wisdom with us. We are bang on time, 7:50. We start 6:50. Start the next talk by Dr. Vishakha. Over to the coordinator, Dr. Josna and Dr. Neha. Thank you, Dr. Anila Malde madam.
For this opportunity. Thank you, everybody.
Thank you very much, sir. So I would like to invite our next speaker for the day, Dr. Vishakha Karnar. She is a consultant anesthesiologist with special interest in transplant anesthesia. She's done her master's in health research with distinction from the University of Stirling, UK, and her dissertation topic was, does sarcopenia or frailty predict the pediatric liver transplant waiting list mortality and or post-transplant outcomes? Has a fellowship in transplant anesthesia from our fellowship in liver transplant at Brigham University Hospital. Also a fellowship from the Royal College of Anaesthetists in 2021 and an MD anesthesiology, obviously from Colombo, Sri Lanka. Her research interests are and the ongoing projects are Sri Lanka Sustainable Operation Theatre Projects, Transplant Anesthesia, Sarcopenia and Frailty in Perioperative Setting. We welcome you, ma'am. Over to you, Dr. Vishakha Karnar, ma'am.
Thank you very much for that wonderful introduction. So I'm just, I think the...
Dr. Vishakha, you can start sharing your slide, please.
Yeah, hopefully. Right. Okay. Here you go. Okay. Right. So I think, thank you so much for that lovely introduction. And it is an absolute pleasure for me to present in this wonderful forum with my neighboring countries in the Saarc, anesthesiology session. So can you see my screen? I think it is post again from your end. I think. Right.
Yes, ma'am, we can see this.
Yeah. Okay, right. So I hope that you can see the slides move. Yeah, okay, right. Sure.
Absolutely.
Right. So, right. Okay. So I'm Vishakha. I'm from this beautiful island, Sri Lanka. So I'm working in ancient city called Anuradhapura, which is about 200 kilometers away from Colombo. And so I think the talk that I'm going to do today is a very important and evolving topic. So I think that it will be brainstorming for everyone. So I hope that you will all enjoy this session. So this is the objective. So we have only one objective. So we see a lot of elderly patients coming to our theater, and they get more and more complex surgeries every day, and it is getting more advanced with days. And what we need to do is, what we need to learn is try and see how we can optimize them to the point that after extensive surgery, they will be mobilized as early as possible, and also to go back to what they were doing. So that is our objective. So to learn how to do this magic. So as we all know that we are dealing with the aging population. So compared to 20th century, this century had made a lot of advancement in the science and the medicine. So which has led to growing elderly population everywhere in the world, not only in developed nations. It is evolving to all the developing countries as well. So this is a challenge because the data from UK has shown that most of the healthcare utilization and the cost is from elderly patients who are more than 65. So because of that, we all have to be ready for this. And so the question is, are we ready? So are we ready for this elderly population who's going to come to our hospitals? And as anesthetist, most of the patients who will undergo the surgeries will be from this age group. So we really have to be ready. And so from a very large systematic review, which was done on cancer survivors, they have attempted to check what the patient want, whether they want survival or whether they want quality of life. So it is confirmed not only from this trial, from multiple systematic review, it is confirmed that what our patient want is the quality of the life, not the quantity. So it's not the length of life, it is the quality of life. So this is the problem. So when we are getting our patients for surgery, so there is a point that, there is a threshold. After that, we really have to be careful. So we sometimes have to advise against the surgery. So that is why we do a pre-op assessment. So we do extensive pre-op assessment. Not only that, we do CPET, we do scores, and sometimes we do a lot of things to find our threshold, to see when to say no. So that is the place that we are trying to look for. So this spot is very, not very easy to find. So to which patient we have to be careful, and also to which patient we need to optimize, and also to which patient we have to book ICU bed and preoperatively plan. So this is the point that we have to find the answer. And so recently, during the last 2 decades, they found that there is a condition called frailty, which significantly affect the perioperative outcome. So that is the place why we are talking about this today. So it has gradually grown, more popular, and because of the evidence, it is considered as one of the most important factor in the pre-op assessment. So what is this? What is frailty? It is a global reduction in physiological reserve, and it also increases the vulnerability of the patients to any even a minor stressor. So why this happened to our patients? So it is strongly linked to sarcopenia. The frailty is strongly linked to sarcopenia, and the sarcopenia and the frailty is linked to aging. Not only that, sedentary lifestyle, malnutrition, and the hormonal changes, and sometimes oxidative stresses, and certain disease conditions like end-stage liver disease, end-stage kidney disease. All these can contribute to sarcopenia and frailty. So it is not only the elderly. So it is not only the age. So you have to be careful in any of the patients coming to your theater. It can be a young patient with a certain medical condition. So you really have to look for it. Unless you look for it, you will not find the frailty patient. So why it is important to the anesthetist? So, I mean, if you look at this curve of functional status, with a patient who has 100% functional status, after a surgical stress, they go back to their baseline functional status nicely. But if you look at a patient who has a already declined functional status, they might not go back to the baseline functional status where they were. So after a surgery, so this is a serious problem, because this will seriously decline their quality of life, that can lead to delirium, peri-op complications. So that is why we need special tools like rehabilitations, ERAS protocol, and tailored anesthetic plan. Not only that, sometimes ICU and HDU stay to optimize and manage these patients very carefully. So that is why we need to find and look for these patients in our everyday life. And it is very difficult for us to escape from this problem. And so this is again a very important trial, which from where we can learn. So this was published in Anesthesia and Analgesia Journal. So they have found that from screen of many databases, they have a screen about 4,000 plus articles, and summarized to 18 articles, which they have used the frail scale to assess the frailty. And so they have found that there's 6-fold increase in the 30-day mortality and 3-fold increase in the 6 months mortality just from the frailty. And also there is higher odds of post-op complications and post-op delirium. So this shows why it is important. And also, when it comes to emergency surgeries, they have found that they are at very high risk of perioperative complications, and also they are at very high risk of even from low risk procedures they can get serious complications. So that this means that even in an emergency setting you have to look for frailty. So it will not be easy because it is a time consuming thing. So and the other thing is they also have found that this is a study which was done in USA, that the severely frail patients healthcare cost is much higher compared to mild or pre-frail patients. So this also shows that they need a lot more advanced care compared to pre-frail or robust patient. So because of that, we have to learn how to assess. So this is because of the novelty of this condition. I mean, I'm sure it is not novel, but it is growing. It is popularity only recently. So with that, sometimes we might not do it routinely in our clinical practice. So we have to learn how to screen. So if you go to literature, there is nearly more than 50 screening tools that we can use for frailty assessment. So, and interestingly, some only use the functional component, like in frailty scale, and certain tools use a combination of physical plus the cognition, and some actually assess the the balance, demographic, general health, and the social aspect as well. So, so this type of comprehensive tools which calculate or accumulate all these assessment of the components of the frailty definitely will take time. So we need to find assessment which is actually comprehensive yet can be done within our time frame, because we do a prolonged, I mean, anyway we are doing a long anesthetic assessment. So this frailty should be just one part of it. It's not the only part of it. So we really have to find a solution which is quick yet comprehensive. So this is a systematic review which was published again in Anesthesia Journal to find the categorize the frailty assessment tools. So they have conceptually divided it into frailty phenotype methods and the deficit accumulation method. So phenotype means just kind of an overall assessment of the frailty, and accumulating deficit method uses multiple aspects, just by giving them a score and giving them a cumulative score ultimately. So examples of the phenotype method is the phenotype and the frail scale, and the accumulating deficit method is the Edmonton frailty scale, which is what we use commonly, and the clinical frailty scale, which is again used very commonly worldwide. And so this is frailty scale. So as you can see, it has 5 components, mostly on the physical aspect. And the clinical frailty scale, it's kind of an overall assessment of the patient. So from very fit to terminally ill. So there's about 9 categories where you can put the patient into one of these categories by overall assessment of the patient. It's not like a score. So, but it's quite easy if you look at it. So you just have to give an overall assessment of the patient. And the electronic frailty scale is kind of a deficit accumulation method, which is electronically, there are sometimes online tool where this can be fed to the healthcare records and get the electronic frailty index calculated. So this is what was actually used in the SNAP-3, which was recently finished in UK. So the frail scale is again, it has 5 components, and so that mainly has physical component. And Edmonton Frailty scale is a very, very comprehensive deficit accumulation method of frailty assessment tool. So it has functional performance, cognition, general health, social aspect, mood. So it has a lot of aspects. So this is a comprehensive assessment, and it is definitely going to take time. So limitations. So when we are selecting an assessment tool for our clinical practice, we have to know the limitations of some of these frailty assessment tools. So the main thing is the time. So if some of these tools take time, and so we need to find a shorter version. But however, the things, the tools like MFI-5 is not yet strongly validated for perioperative practice. So the other limitations include some of these assessment tools does not include cognitive aspect. And if we have physical measures, the person who is doing has to be trained. So that also a very important aspect that we need to understand. So what is the ideal method then? And also what should be used in our perioperative practice? And if we are going to use many tools in the world, so how can we compare? So this is again a very interesting systematic review which was done in 62 countries. It was done to find the prevalence everywhere in the world, but however, they could not find evidence from everywhere. So that's why they have just stick to 62 countries. So this is this actually has done the screen in most of these main databases, and have sum up to like 200 plus articles. And so interestingly, so they have found that the studies that they have screened has used multiple frailty indexes, including frail scale, Frailty Index, and Edmonton. So, there's a lot, Prisma. So, so I told you at the beginning, there's 50 plus tools. So, so that's again a problem that you will encounter when you are going to the literature. So this is a summary in different areas in the world. So they have found the total cumulative frailty, the prevalence in this whole meta-analysis was about nearly 12% from the frailty phenotype type of frailty assessment. And when it comes to deficit accumulation method, it was about 24%. These are two different types of studies. So whether it is due to the tool or due to the two studies is a question, but it has ultimately given two data to two areas. So it's quite surprising, and it again shows the problem with the different tools. So it actually has doubled. So just to look at the Asia, so we are not too bad according to this study. So we don't have to be very sad. So the lowest frailty and the highest frailty was detected according to this study in Africa. And it is not only elderly. So according to the same systematic review, they have found that about 11% prevalence in age group between 50 to 59, again alarming. So, we just, if we just go to our region, since this is a Saarc forum, I thought that it will be interesting. So please don't get offended. So these are some of the studies that I found. So there's quite heterogeneous numbers in the same country. So I just try to give them a range. even though Sri Lanka has a lower number, it is very difficult to believe. This was a study which was done in near Kegol, which is in between Colombo and the peripheral area. So I think the number must be definitely higher than this, even in our country. So it is interesting. So we need more studies to find what is the exact number. And and the other thing is what is recommended by large clinical societies in the world. So the Perioperative Medicine Society has given a guideline on this frailty, this pathway. So what they have recommended is the clinical frailty scale and the electronic frailty scale. So as I said earlier, the clinical frailty scale is very easy, and you have 9 components. And electronic frailty scale is a matter of just entering your data into your computer or the phone. And so you can use these tools most likely because this is recommended, and also you have a lot of data on these 2 scores, and it is very easy to use. And the prevention and the management. So this is again a very important aspect. So they have recommended this PROMISE tool. So physical activity, resilience, oral health. So this is what they say is if you save 1 teeth in elderly, so outcome can be improved by nearly 9%, which is interesting. And management of non-communicable diseases and involvement in the society, and smoking cessation, and eating different type of food. So this is evidence on the management, modalities, and the best evidence is there for group-based exercise programs and supplementation of protein and nutrition. And the others, I mean, there is some evidence, but we are yet to have a strong evidence on those aspects. So if a patient comes to emergency surgery, what do we do? So this is from the perioperative guidelines. So what they say is to use the clinical frailty scale and document the frailty, assessment before they proceed, and document, and also ensure that you have screened for any DNA CPR orders before you proceed, and then follow the emergency care pathway as per usual. And depending on the frailty, you might have to consider, depending on the urgency, you have to consider optimization and the location of the care. And if it is elective surgery, from the primary care itself, it is recommended to screen for frailty, and then again screening in the hospital as well. And then in the theater, so ensure that you know that the patient is frail, and use advanced hemodynamic monitoring depending on the condition. And this is again a very important aspect, the prehabilitation. So it has multiple aspects, including medical, physical, nutritional, and psychological support. And it is very, very costly. So you need a lot of people to do it. Psychologists, exercise therapists, nutritionists, smoking cessation counselor, alcohol, and a lot of people, anesthetists. So it is a multidisciplinary team. It is very costly, and this is a prehabilitation triangle. So it need to be carefully assessed. And do we have evidence for prehabilitation? So this is a very recent BJ article which was published, and they have questioned the evidence, because even the no prehabilitation and no complication group has gone higher up compared to prehab with complications. So we are yet to find what is the correct rehabilitation technique. Maybe that's the reason. So I just want to reshare this slide again. So this is where we started. So we really have to find what our patient want. It is not the quantity, it is the quality of the life. So you really have to be the anesthetist who will look for the place or the point where you have to decide that I'm just going to optimize this patient, I'm just going to delay this surgery and just optimize a bit more, and just find the point where we can actually give them that same quality of life after surgery. So it is not easy. So in summary, so patients choose quality of life over the length of life. So just know it. So so since the frailty is an independent predictor of post-op outcome, please measure it. So you can use CFS, so electronic frailty index, and perhaps is yet to be validated, but still I think it is a very nice technique to be utilized. So just 1 minute ahead. Thank you so much. So I think I would like to thank Dr. Naveen and all the team for this wonderful session and continuing this program to share the knowledge and to be with our neighbors, neighboring countries, anesthetists. It was very nice and pleasure to be with all of you. And if there is any question, I would like to answer these before I finish.
Dr. Vishaka, it's a very relevant topic and you covered it very comprehensively. Thank you so much. We have got one question in the chat box. Emergency frailty scores are best correlated to clinical assessment. That's an observation by Dr. Raghunandan.
Emergency frailty scores are best. Sorry, I missed. Yeah, emergency frailty scores are best correlated to clinical assessment. Yeah. So it is actually it is the overall look. So emergency. So what is recommended is this clinical frailty scale. Sometimes we look at the patient, and sometimes the anesthetist would just say that I don't feel and I don't feel that this patient will do well. So that overall clinical assessment. And but clinical frailty scale actually go beyond that look, just bedside assessment. So it actually goes into the details about the functionality, and so that actually gives a very nice idea about how this patient will do. So, and as I said earlier, so what we need is to get them and give them that quality of life. So I think looking at it, I think it is very important that we assess even in emergency the frailty assessment, and then we can hopefully decide the level of care and how fast and how intensively we need to monitor the patient. So all these things can be guided by this frailty assessment.
Thank you. If there are any more questions, please ask in the chat box.
Unmute कर रखा है आपने आपको? Now it's time for all to they can interact with Professor Anila Malde as well as Dr. Vishaka.
There is a question in the chat saying that is there a cutoff for age group? So actually, these frailty assessment were actually initially validated in more than 65. So we recently started a study on Edmondson frailty scale on patients over 18. So that is anybody. So we are trying to see whether our general population is frail. So there is no cutoff, but we really have to know that the data that we are having are from patients who are more than 65. Whether it can be used in young population, we don't know. But there are disease-specific frailty scores. Like, for example, we have liver frailty score, which has grip strength, chair stand, and the balance. So like that, there are individual frailty scores for different conditions. But they have not specifically mentioned age, but we really have to know that it was initially validated for elderly.
Yes, thank you so much. Any more questions for both the speakers, please?
There are some questions in the chat. Can I answer?
Yes,
So
yes,
which single screening test do you recommend before routine surgery, ma'am? Is the time up? And yeah, so it's actually, so it is not me. So I think let's stick to the guidelines. So Perioperative Society has clearly mentioned to use the clinical frailty score or electronic frailty score. So clinical frailty score is, I think it's much easy because it's just looking at that picture and just, picking where is this patient. So it's very easy. So we can easily use it. And geriatric, yeah. So I think the clinical frailty score and the electronic frailty score is also recommended, but for emergency surgeries, they have recommended clinical frailty score, and for electives, so they have recommended clinical and electronic. So if you, so we are yet to get the results of the SNAP-3, which is one of the largest audit which was done in UK. I was involved in that audit. So, so actually it was a 1 week screen of like most of the country in UK, just to find the frailty score of these patients who are coming for elective surgeries, and to see whether it is correlated with the post-op delirium. So they use the clinical frailty score and the electronic frailty score. So I think these two will be the future most likely, because this is a large audit and it will give us a lot of insight. And in the future, there will be more and more studies, and we need something quick because we are anesthetists. We use quick things and quick drugs. So I mean, so I don't think we'll use Edmonton or something which is very comprehensive like a geriatrician. So I think we'll stick to a quick assessment most likely.
Is frailty a preventable state at old age?
Yeah, it is. So I think I discussed about the preventive aspect. So it is promise. So you need to be active, and so I think as Indians, so something like yoga or something which can be promoted, and you know, community engagement, improving of the cognition. So all these aspects do prevent. So this, I think it is mostly a community level project rather than something that we can do as anesthetist, but it is preventable. Yeah, so that's an interesting question, madam. Will we all get frail if we live to very old age, or is the fragile part? It is not all. So it is actually it is quite specific, and there is correlation to vitamin D, and there are a lot of factors affecting that. And there can be very fit 80 years old, and there can be very unfit 60-year-old. So I mean, I'm sure you can be. I mean, just you start today, you'll be all right. You'll be very fit anesthetist at 8 years old. It is preventable. It is entirely preventable. And but certain disease conditions like liver disease, chronic kidney disease can lead to progressive muscle loss and cancer. So these conditions can lead to very serious frailty, but still it can be prevented by gradual exercises and nutrition. I wish you all good luck. So I think it is nearly the end. So I'm sure you all will not be frail. I really wish you good luck.
And
Thank
we
you so
are,
much.
we are very happy to have you on board. And it was pleasure having both Dr. Vishakha and Dr. Madam Anila Maldev. Before I invite Dr. Virendra Sharma for vote of thanks, on behalf of Dr. Banik from Bangladesh and Dr. Kavachar sir from Bangladesh, okay. You are all cordially invited for the 15th Saarc phone se kar lo. Saarc conference. The flyer is being just displayed. It was displayed earlier also. So you are all cordially invited to participate in huge numbers in Saarc 2024, the 15th Congress of Saarc Association of Anesthesiologists at Dhaka, Bangladesh. And it is in collaboration with the 50th Golden Jubilee celebrations of Bangladesh Society for Critical Care and for Bangladesh Society of Anesthesia, Critical Care and Pain Physicians. Over to you, Dr. Josna and Dr. Neha, to carry it forward.
Thank you very much, sir. Thank you very much, sir. I would now like to invite Dr. Virendra Sharma, sir. He's the treasurer. He's the treasurer of Saarc AA. He's a consultant anesthesiologist at Vivekananda Polyclinic and Institute of Medical Sciences, Lucknow, and also he's the past treasurer of ICE National. Welcome, sir.
Thank you. Good evening, President Saka, Dr. Venkatgiri, Dr. Naveen, Secretary, my colleague Dr. Anjali, the two speakers, senior members from our Saarc countries. With subsequent webinars, what I'm observing is that our strength is those who are attending is continuously growing. And I think in future, it will be challenging for us to keep the topics interesting and continue this tempo. And now, many of the members whom I saw in previous webinars, they have become now consistent representative of these webinars. So it's good. We are sharing our thoughts and be in touch. And of course, as I spoke in the last webinar, that this time we should see more members going to Saarc conference at Dhaka. So all the best to the organizers, and expecting Naveen to declare soon the next webinar. Thank you.
Thank you so much, sir.
Thank you very much, sir.
Over to Naveen, sir.
The next webinar will be on 30th August 2024, the last Friday, as we continue, and that thing will continue in all the subsequent months. So we have got, I place on record deep sense of appreciations for all the president and secretaries of the constituent associations. Dr. Arian regularly attends it from Afghanistan, and we have got Dr. Amir Babu Shrestha from Nepal, and definitely today the host team of Sri Lanka was there in big strength. Thank you all the speakers. Without your active participation, this webinars won't be that enriching. You are the backbone of all the academic programs, and I thank you the coordinators, Dr. Jyotsna and Dr. Neha Sinha, for nicely coordinating it. See you next month on 30th August for the next webinar. Thank you very much.
Thank you.
Thank you.
Thank you very much.
Thank you, sir.
everyone.
Thank you, Dr. Naveen. Thank you so much.
Thank you, Naveen sir.
Thank you, everyone.